Why will it happen? Whenever the normal dicrotic notch which will occur with the aortic valve closure that become exaggerated, that lead to the formation of this dicrotic pulse. Can you tell me a few situations where it can happen? If there is a low cardiac output, or if there is a low peripheral resistance, that is one important situation. So hypovolemic shock, heart failure, young patients with fever whose total peripheral resistance has fallen down. In all these situations, this dicrotic notch become exaggerated, leading to the dicrotic pulse is what I want to underscore to all of you. But the second one is seen in diastole, first peak is seen in the case of the systole. How do you know it is diastole or systole, doctor? Here the S2. S2 is closure of the aortic valve. So from then onwards what will happen? Heart will fill. So that's the reason, doctor, after S2, the second peak comes in the case of the dicrotic pulse. It is seen in the case of the diastole is what need to be remembered. So whatever be the story, finally you need to know pulsus Bispherians in a given case of aortic regurgitation. In the exam hall, if you are checking in the brachial or radial artery, examiner will say, what is this? Here, carotid artery is there, is what he will be giving you a clue. If you could not catch what is here, then he will say, come after 6 months. So that's the reason, doctor, pulsus Bispherians, look at the carotid, we see a good number of aortic regurgitation plus AS cases. Can you tell me one classical cause in our context? Rheumatic heart disease. You can find full garden variety of valvular heart disease. So walk into the wards today only, in aortic regurgitation, wide pulse pressure is there, look at the carotid, you can see the presence of that Bispherians pulse, now you are very sure about. Let's go to the next question. In hemorrhagic pericardial effusion, what are all the various causes? Generally, metastasis to the pericardium, like the lymphoma, lead to the development of this hemorrhagic effusion. Aortic aneurysm dissection also can ooze the blood into the pericardial area. Similarly, transmural myocardial effusion, these are all considered to be what you call examples of hemorrhage, but not constrictive pericarditis. So this kind of water bottle appearance of the cardiac silhouette in the pericardial effusion is unforgettable, especially a young female who has got the systemic lupus erythematosus has come to you. The SLE is known to cause variety of serositis. It can lead to pleural effusions, it can lead to ascites, it can lead to pericardial effusion. So take a radiograph, this kind of water bottle appearance is there, don't forget about the pericardial effusion. Let's go to the next question. Pleural biopsy. One or the other question nowadays is coming on thoracocentesis, pleural biopsy, let us be very sure about. So please remember, doctor, what are all the various complications? 5 complications of the pleural biopsy, unforgettable. Hemothorax, empyema, pneumothorax, seeding of the tumor, extravasation, these are all very important, but not pulmonary embolism. All the remaining things can be the complications is what you need to fundamentally remember. Let's go to the next question. There is headache and sweating. So case study based questions are also coming in the state entrance. There is no exception, doctor. So level of exam is improving. Let us improve our level also on the Glasgow Coma scale. So headache and sweating is there. And typically there is epigastric pain, and there is thyroid nodule with the toxicity. So these are all the features which are suggestive of multiple endocrine neoplasia. Which type, doctor? Type 2A, Sippel syndrome, has got medullary carcinoma of the thyroid, pheo and parathyroid hyperplasia with the associated hyperparathyroidism, which can lead to the epigastric pain is what I want to underscore to all of you. Hence, you are expecting pheo in her, so serum and urinary catecholamines would be a better choice is what I want to underscore. Regarding type 2B, what are you going to remember, doctor? Typically, linkage with the RET oncogene should not be forgotten in relation to the type 2B. So one or the other question will come from men's syndromes, doctor. Another important Murphy's law. What is there? Finally, CMDT this end to that end, you have finally grinded any question you can answer. But in the last moment you need to know how to selectively prepare, doctor. That's very important. So pheochromocytoma, medullary carcinoma of thyroid, lumpy bumpy neuromass of the mucosa in the marfanoid habitus is unforgettable. Now our most favorite question has come, doctor. Multiple sclerosis. What is the typical feature? Internuclear ophthalmoplegia will be found. What is internuclear ophthalmoplegia? It connects between which and which cranial nerves, doctor? 3rd and 6th cranial nerves are connected by the medial longitudinal fasciculus. When you look towards your right horizontal conjugate gaze, the left eye need to undergo adduction, the right eye need to undergo abduction. Then when my right eye is undergoing abduction, Who will tell that my left eye need to undergo adduction? It is the MLF which connects my abducens of the right side to the oculomotor of my left side will tell that my left eye need to undergo the adduction. If the medial longitudinal fasciculus is basically injured, what will happen? When I am looking laterally, my right eye can abduct, but my left eye cannot adduct because it has no news about the other eye is abducting. Now you may ask a question. How can you say, sir, that your left eye is not adducting because of the MLF problem? Probably there is a problem with the oculomotor itself. That is the reason that it is not adducting. How can you differentiate? Very simple. Ask the patient to converge medially. So then both the eyes will converge. So convergence is normal because two oculomotors are guns individually. But when they need to work together like the Indians, we generally fail. So there one eye will be abducting, other will not be able to adduct. Now what will happen in that abducting eye? Because other one is not cooperating, it is not adducting, it creates a diplopia. To overcome the diplopia, immediately what will that abducting eye will do? It will undergo a nystagmus. So that's the reason the nystagmus will be there in the abducting eye is what I want to underscore to all of you. So that's the reason, doctor, nystagmus of the abducting eye is a feature which you see in the case of the internuclear ophthalmoplegia, which is because the lesion in the case of the medial longitudinal fasciculus, which will be connecting the third and the sixth cranial nerves. Now the question is, what is the most common cause for that? It is the demyelinating plaque, which is involving the brainstem and involving the medial longitudinal fasciculus. Multiple sclerosis is the most common cause for the internuclear ophthalmoplegia is what need to be remembered. Now next you need to know what is this 1.5 syndrome. But before that, let us summarize by this illustration, doctor. The individual is looking straight, this is a primary gaze. But when he is looking onto the what you call the left side, he is able to do it normally. But when he is looking towards his what is this side? Right side. His right eye is able to abduct, but the left eye could not do that because it is the adductor lag it is suffering from, and this eye immediately will be, this abducting eye will undergo a nystagmus. That is what happens in the case of the internuclear ophthalmoplegia. Whereas if you ask him to converge, both the eyes can converge normally is what need to be remembered. Multiple sclerosis is one of the important cause. Any head trauma or brainstem neoplasms, because this third and sixth cranial nerve nuclei are located within the brainstem is what need to be remembered. Any AV malformations or hydrocephalus can be responsible is what need to be known. Now the question is, will this medial longitudinal fasciculus, is it on the side of that adductor lag eye or the nystagmus having abducting eye? Which side is the lesion in the medial longitudinal fasciculus? Suppose if my right MLF is defective, will my left eye suffers the adductor lag or will my right eye suffers the adductor lag? So easy way to remember is MLF lesion, typically the eye will be ipsilateral to the side which is not able to adduct is what I want to underscore to all of you. So it is ipsilateral to the insufficient nasal output. INO is internuclear ophthalmoplegia. So insufficient nasal output means adductor lag. So it will be ipsilateral towards the eye which is having the adductor lag. That side MLF is there. So whenever I am having a right lateral conjugate gauge and my right eye is abducting but my left eye is not able to adduct, then my left side MLF is at lesion is what you have to fundamentally remember. So this you can see, doctor, he is able to abduct normally, but whenever he is able to converge normally, but you can see there is a nystagmus in this abductor eye, and whenever he is abducting, this eye is not adducting, and that is the reason there is a nystagmus which is set in the abducting eye. That is the typical lesion in the case of the MLF, that is the internuclear ophthalmoplegia is what need to be remembered. There is something called 1.5 syndrome. Let us be clear about this also. Another favorite question. Typically there is a conjugate horizontal gaze palsy in one direction. That is one of the eyes is not able to have the what you call conjugate deviation, and there is internuclear ophthalmoplegia in the other. What is the reason for this? The reason is in one eye there is a MLF problem and in the other eye the abductor nucleus is gone. If both the things happen, then it is called 1.5 syndrome is what I want to underscore to all of you. Now you can see in this given case, doctor, the right eye is deviated outward in the primary gaze And the conjugate horizontal gaze palsy is seen to the left for the voluntary track towards whenever he is trying to track his eye, then the conjugate horizontal gaze palsy is seen. So the combination of the MLF lesion of one eye and absence of the other is called the 1.5 syndrome, is what need to be remembered. Now one more option is given, pendular nystagmus. Is it also seen in the multiple sclerosis? Let us be sure about. But before that, what do you mean by pendular nystagmus? Generally, doctor, whenever the eye is undergoing nystagmus, it will have one particular side preponderance. That's called directional preponderance of the nystagmus. Suppose if the nystagmus is happening roughly in the same velocity in the both directions, it is called as the pendular nystagmus, is what need to be basically remembered. So it can happen in the blind individuals. Nystagmus is typically pendular. So with the lesions of the central tegmental tract, which can occur because of a demyelinating condition like multiple sclerosis, there can be development of this pendular nystagmus. There is a typical condition called spasmus nutans. It also leads to development of the pendular nystagmus. What is this spasmus nutans, doctor? Typically, it is seen in the case of the children. They will be having head tremor, torticollis, and in addition to that pendular nystagmus. But generally, it will be resolving by about 1 to 4 years is what I want to underscore. So anyway, we reached until the neck of the nystagmus. Let us clear 2 more nystagmus, doctor. This is called an upbeat nystagmus. Commonly you see. So nystagmus is not a hallucination. One of my professors used to say, it is your hallucination that you know everything is responsible for your hallucination that you can't see the nystagmus. So see carefully, you will find nystagmus in n number of patients in the neurology ward. So this is upbeat nystagmus. So where do you come across it? If there is any lesion in the medulla, ventral tegmentum, or in the midbrain, upbeat nystagmus can occur. Even in the smokers also, excess nicotine is there, then they will start having the upbeat nystagmus. And in the Wernicke's encephalopathy, even in multiple sclerosis and in the brainstem infarction, you can come across this upbeat nystagmus. Then you have another condition called downbeat nystagmus. What is this, doctor? It is classical in the case of the Arnold-Chiari malformations, which we discussed in very detailed in pathology. So that's the reason at least you need to remember here. So what is the most frequent cause? Any cerebellar or spinocerebellar degeneration, even in multiple sclerosis or any cerebellar problem, it lead to a downbeat nystagmus. Typically posterior fossa involvement lead to downbeat nystagmus. Then you are having another type called seesaw nystagmus, is what need to be basically remembered. So now you are very sure this is the end of the nystagmus, doctor. Let us go to the next question. What are the complications of the mumps? It can lead to meningoencephalitis, myocarditis, pancreatitis, but not the myositis, is what need to be basically remembered. I'll try to go a little faster. We need to finish 200 questions. What is the most effective treatment of the chronic myeloid leukemia? This is a challenging question. How many have answered autologous bone marrow transplantation? Can raise the hands. Or do you think chemotherapy can be a better option? Basically, is there any change in the frame of the question? Yes, yes. Allogenic or non-allogenic? Okay. Chemotherapy is also given, hydroxyurea is also given, no? That is also truth. Now the thing is, CML at one point of time is a big issue. But nowadays, there is a wonderful drug which was discovered that has taken care and revolutionized the therapy of the CML. What is it, doctor?